My name is, thank you, my name is Robert Joseph Taylor. And this term is the Program for Research of Black Americans and the Michigan Center for Urban African American Aging Research are pleased to host the Group Dynamics Seminar. This is one of the longest running seminar series in the social sciences. Before I start, I'd like to mention a few of the next speakers. So next week we have Marvella Ford, who'll be talking about retention of African Americans in research. Probably based, because she's a gerontologist, I think she'll probably speak a bit more about African American aging, but generally about retention, recruitment and retention. After that, we have Taylor Hargrove, who's a young sociologist from University of North Carolina, speaking on the impact of skin color on physical and mental health. And then the next speaker is David Williams from Harvard, speaking on wealth and health disparities. Now, his talk will be on Tuesday, starting at 2:30, and you'll have to pre-register for that talk. You'll see, if you haven't seen the ads already, you'll probably see some ads pretty soon. So let me talk a little bit about today's speaker. So today's speaker, Tabb, Dina, is an associate professor in the School of Social Work at the University of Illinois,
Chambana.
Yeah. Urbana. Let me just mention, I sort of messed that up because I was thinking of one thing I really wanted to say. She is an associate professor for 2 weeks. So she She is interested in women's health and mental health disparities. Her research in particular focuses on the social determinants of health and mental health for pregnancy and postpartum women, especially among racial and ethnic minorities. She received her bachelor's degree right down the street from Eastern Michigan. She received her MSW here at Michigan, and she's attended several programs sponsored by the Program for Research on Black Americans. So, and one last thing, she attended ICPSR as an MSW student. So let's please welcome Dr. Karen Tabb Dina.
Thank you. Thanks. Good afternoon to you all. If you can't hear me for any reason, just raise your hand. I'm standing in front of the podium because today's talk is wildly important as a national priority, but then also personally. I'm expecting a baby, so this material is even more near and dear to me right now, okay? I have nothing to disclose, nothing yet, maybe someday. For the academics in the room, these are famous people. Okay. These are celebrities. And what makes them remarkable is that all of these celebrities have come out in the past few years and said, what happened? I had a baby and it was supposed to be this joyous experience, but something wasn't right. Or I nearly died. Or why didn't anyone talk to me during my pregnancy or after I gave birth about what really to expect? Or ask me what was going on. All of these celebrities have experienced a perinatal mood disorder. And I'll go into exactly what that means, but it's a mental health situation, and many of them, these women found themselves at a point of crisis. We as a country are grappling with this topic, and I'm grateful for these stars because it's the voice of celebrity that have been able to push forward a research agenda that several of us have been working on for decades. Just last week, the United States Preventative Task Force accepted recommendations to start addressing perinatal mental health during pregnancy and the postpartum. This is monumental. So we're saying we need to stop looking at just postpartum alone, but the experience of depression and mental health disorders during pregnancy. And we need to identify treatments and ways to identify women in need of mental health care. I keep saying the term perinatal. What I mean is my experience right now. So the point from pregnancy until 12 months after delivery. So it's almost a 2-year window. Some might say that it's narrow, and some might say that it's pretty broad. Mental health problems during this period are rampant. So you often hear the statistic that 1 in 5 women are going to experience a perinatal mood disorder. And under the umbrella of mood disorders, there are a whole host of different things that are going on. The most common being depressive disorders. So on this table here, we have depressive disorders broken out by major depressive disorder and dysthymia or minor depression and bipolar disorders. The red corresponds to the prevalence during pregnancy, and the blue, the prevalence during postpartum. Now, these are CDC figures, so the Center for Disease Control and Prevention. They're still the best that we have, but they're nearly a decade old. Okay? We as a nation are getting better at identifying depression, perinatal mood disorders, so the prevalence seems like it's increasing. We're just identifying more women in need. I want to point out something that's pretty notable, and that's psychotic disorder. Every time I present this information to a lay population, especially like first-time pregnant mommies, they want to know about psychosis and if they're at risk for psychosis. And again, I want to stress that this is very real, or very rare. It's very real, and it's very rare. Less than 1 woman out of every 1,000 are going to experience this. But when it happens, women often hear the voice of a higher power, or these perceptions of grandeur, that something is going to happen to them and their infant. I know one of my groups is working with grandparent psychosis right now, which is a newer topic. Let me not go there. But it's a serious situation, because these are the situations that we hear on the nightly news of a mother taking her own life and the life of her children. My state is the first state in the country, the state of Illinois, to sign in act to examine perinatal psychosis. Off the cuff, we're calling it the Infanticide Act. It's the first one in the country. We're very late compared to other countries like Britain, but it was signed into law June 30th of this past calendar year, and my state is reviewing 20 cases of women that probably had perinatal psychosis when they committed what is called a forcible felony. That could be murder, it could also be hitting someone with a car. So very rare, but something that we need to do more about, and hopefully Michigan can follow suit. Okay. I mentioned the major causes of perinatal mood disorder are perinatal depression, anxiety, bipolar, and perinatal psychosis. These are the major camps. As you may know, maternal mortality is increasing in the United States. We're now up to 26 per 100,000. It sounds like a small number, but it's an alarming number. We were down to 7 in the year 2000, and we've steadily increased since. Wrapped up in our high maternal mortality rate are factors of race, ethnicity, which is why I'm here today, thinking about groups and group dynamics. Also within this are mental health issues. In the United States, with a maternal mortality rate of 26 per 100,000, we're learning that the causes related to maternal mortality are not pregnancy related, as they are in other countries. Things like sepsis account for 2% of these deaths, where others like suicides are the second leading cause in this country. So in the US, we're faced with suicide and homicide being those leading causes. Accordingly, my program of research and my team looks at perinatal depression to help tease out some of the burden of morbidity in this population and the increasing mortality. So perinatal depression is a specific mental health disorder, affects 8 to 20% of women. We still don't have a firm prevalence because that's across studies that are all different sizes, shapes. And of these 20% of women, Less than half of women are ever going to have a discussion with a provider about their perinatal mood disorders. Less than half of those women are ever going to receive any sort of treatment. Okay? Treatment is the key word, because by treating, we can address the problem. We now know that untreated depression is related to a whole host of factors for mother and child. And that's just starting with mother and child. That's not even talking about family systems and those dynamics. Untreated depression during the pregnancy is related to intrauterine growth restriction, so babies that aren't large enough as they should be. Preterm birth, which is also associated with low birth weight. It's associated with obstetric risk for mom. We're starting to learn that untreated depression is related to gestational diabetes even, increased C-sections, decreased pain tolerance, coping or substance use behaviors, so the use of tobacco and illicit drugs during pregnancy. After baby is born, untreated depression is related to impaired bonding. So that's an inability for the mother and infant dyad to bond, which affects the child's cognitive development as they grow older. Some European registries have looked at untreated depression and the longitudinal nature of what happens to that offspring later. And they find that these factors are related to suicidal ideation in the teens and some behavioral problems in the teens. And then in the postpartum, or hopefully the conversation couldn't go today, but in the postpartum, untreated depression during the pregnancy is related to postpartum depression. And that might seem straightforward for you all, but this is novel science in the last 10 years. So untreated depression is related to postpartum depression. It's related to suicidal ideation, suicidal completion, and maternal mortality. Okay? So again, we're in a room today talking about social dynamics and how do we start looking at groups and understanding the extent of our social problems so we can come up with solutions. My team is the Identifying Depression Through Early Assessment, or IDEA, research team. Again, we're in the state of Illinois, so all acronyms should start with an I, just kind of a rule. So everything's I something. So we're the IDEA research team. These are some members of my team pulling paper charts. Okay. So in some clinics, if we have to, we use paper. Thankfully, almost everyone is on board with electronic medical records in 2019, but we do a lot of photocopying. And we're looking at factors during pregnancy, those social determinants that are related to adverse pregnancy outcomes and even adverse birth outcomes. We're very much interested in place, race, age, ethnicity, income, and mortality. And we've published across all of these lines. Today I want to give you a few examples of how we're looking at groups differently to determine how the prevalence of mental disorders actually varies significantly across groups, and maybe we can identify clinical targets for intervention. And then I'm going to leave you with an example of what we're doing that involves patients improving clinical care to address a lot of these epidemiological findings that can feel daunting, right? You're like, oh, another problem, oh, another problem. Where's the solution? So hopefully I'll end on a solution with you all today. So on the topic of place, the clinics that we work in are similar to southeastern Michigan, but we have a larger rural catchment area, okay? The clinics that we work in serve 40 counties, almost all of which are rural, and they span 2 states. So if you think of your geography, Illinois is the I-state in the middle. Then there's an I-state to the left and I-state to the right. We're sandwiched between Iowa and Indiana. And our catchment area is downstate Illinois, so we're 2 hours south of Chicago. All this catchment area of rural Indiana. Okay? So especially those high-risk pregnancies are going to travel in. So I kept the method simple. Just to let you know, we use electronic medical records. We use chart data that's entered by clinicians. We captured data on 10,450 postpartum women. Not the ideal time, you might think, because most research on postpartum depression looks at women 4 to 6 months out, where episodes should usually occur. But these are women who are screened for depression in the maternity unit. So they've just given birth, and they're screened for depression. And you might think one of two things. They're miserable, they're going to say they're miserable. The questions are looking at those psychometric properties around sleep, appetite, desire to do things. I've been in labor for 4 days. I don't feel like doing anything. Or you might think the drugs are working really well. They're going to be really happy. So you might think that data is skewed one way or the other. And we wanted to check regardless, because this is the usual standard of care. And this is the standard of care that takes place in most states that have a depression screening in place. They screen them when they have them. They have them after they deliver. So they do a quality check before the women go home and make sure that there aren't elevated depressive symptoms. We use this thing called the Edinburgh Postnatal Depression Scale. It's a tool, and in 2019 we still give out paper in our clinics. So it's a piece of paper with 10 questions on it. And each question ranges from 0 to 3 points. So the range is 0 to 30 points. And clinically, in the clinics where I work, we use a 9-10 cut point. So women who answer whatever, like I don't have an appetite, and I didn't sleep, and I felt sad, and I kept crying. Their score is an 11. They met that threshold, they'll receive follow-up. Oftentimes a perinatal social worker in the maternity unit will come in and speak with them before they're discharged. Using this scale of depressive symptoms, so it's not a diagnostic tool, it's just symptoms, we immediately saw that there were differences that stood out in terms of the prevalence of depression by place. Okay? Where the rural and out-of-state women reported 8 to 11% prevalence of elevated depressive symptoms, and the suburban women, who are mostly from this college town, so 140,000 people cooped up in a college town. Sound familiar? 8.5% of them reported depressive symptoms. So again, this is a little bit lower than what we'd expect for a national average. We expect something more around 12%, but they're in the maternity unit, right? And it's asking for a 7-day recall. Like, I don't know how I got through the last 24. So you're asking them to dig back 7 days. In a multivariate regression analysis, just quickly, this is all of the variables, so race, ethnicity, age. We use health insurance as a proxy for income because that's the best that we can get out of these electronic medical records. I just want to draw your attention to residence and risk for elevated depressive symptoms. My little circle moved down. That's fine. It's like underlining rural and circling outside. But compared to suburban women, rural women had a 33% higher odds of experiencing elevated depressive symptoms, and out-of-state women almost double, okay, the odds of experiencing elevated depressive symptoms. These findings are all new, okay? They're either under review or published in the last month. Because based on this sample at a major delivery hospital that served both urban and rural women in a huge catchment area, our team decided to look at some national data. I'm going to go quickly to those methods because these are just illustrative examples. And we use PRAMS, which is the Pregnancy of Risk and Monitoring Surveillance System, through CDC, the Centers for Disease Control and Prevention again. We use data from 14 states, 17,000 women. The question they have is a self-reported measure. They ask all of these women, during your pregnancy, did you have any of the following health conditions? And there's a scorecard. You say yes or no, and depression is one. So of these, 23% of women who are rural dwelling responded yes, compared to 20% of urban women. And Michigan is one of the states that we included, okay? So Michigan is one of the states. And the point of this study was to examine, this was specifically for rurality, I can't say that word, rurality, to look at the rural nature of depressive symptoms during pregnancy and the postpartum. As you see it, just the top line here, rural women, again, the 21% higher odds of responding, yes, I had depression, even though it's a self-reported measure. We adjusted for a number of factors, and this attenuated some of the strength that we were seeing in the association, so it was no longer significant. The factors that weighed in were attending a WIC program, like having access to WIC, having public or government insurance, which in our state is and PRAMS is mostly Medicaid, and then maternal education. What is notable in the paper, not on this quick chart, is that even though these factors attenuated the strength of the association that we saw, it's no longer significant, the rural women had less access and lower education compared to urban women, and they were less likely to use WIC was the major program that we were looking at. And another quick example, I want to highlight race and what we're doing around racial and ethnic disparities, at least identifying racial and ethnic disparities in our data that we think is novel. So it's 2019 and we're in the ISR building. Many of you probably have your census caps on because it's next year. Time to enumerate once again. And we're still playing around with exactly how this is going to look, not we as in me, but the OMB, okay? Is deciding what the final census is going to look like. And if we're going to ask about ethnicity and immigration, what are we going to do? One thing that we're not toying around with, that I haven't heard, is changing the new-ish way that we ask about race. So you've probably seen this question, what is your race? Mark all that apply. You probably don't think twice about it. But this was relatively new. In the 2000 census, the change was made to let people allow for more than one self-reported category. And this has had a ripple effect on the work that we're doing in our clinics, because now individuals are selecting 2 or more races. And in terms of health services research, we're not really sure what to do with them. And if this group, this 2 or more group, is a major priority, or if they're large enough to count. Well, the 2000 census was the first time that we allowed 2 or more categories. This continued in 2010, and nearly 9 million Americans, or 3% of the population, selected 2 or more races. So there's been a 32% rate increase, and this increase, or this trend in reporting 2 or more races, is expected to continue. Okay? For the theorists in the room, there's theory slides at the end if you want them. But we're using self-categorization, right, is the approach, and rather than enumerating or reassigning. And the Pew wrote an interesting report on this in 2015, basing race upon grandparents' racial identity or ethnicity, and said that 16% of all adults are multiracial. We know that's not true. It's 3% because it's self-identified. As adults, most people select one race. And that's another talk for the seminar series, but they mostly select one race. Okay? How it relates back to perinatal mental health is that the CDC has started to adopt these categories as well. Not really knowing what to do with it, just saying, oh, okay, there's now this 2 or more group. They're getting large enough to count. Let's parcel them out and report multiracial estimates. So there's a 2015 CDC report saying across 4 states, mostly Western states, multiracial women had the highest fertility rates. It didn't explain what multiracial means because they're lumping this single group. And it didn't explore the heterogeneity. So there's work with a scholar named Schimpf in 2003 And it said if we look within the heterogeneity and perinatal birth outcomes by specific multiracial groups, and in her case, they were in Hawaii using vital records. Hawaii is our largest multiracial state, if you think of it that way. They said you look at within these specific multiracial and multi-ethnic groups, you'll see different patterns of health outcomes emerge. So in the last year, my team, my chart gathering, photocopying team, has decided to include this group, the multiracial group, in our work. Some of our data lends itself to doing this, some does not. One of the hospital systems where we have a perinatal depression registry just uses other for everybody. Everybody that can't be placed. They could be Turkish and they're other. Like, and you'll hear the providers like, I don't know what language they were speaking. I didn't know what they were. Other. So we don't use that data set for this. But we have a smaller public health sample where people identify as however they self-categorize, and they choose 2 or more races. We're also using data out of California, the second largest multiracial state, to see what those differences are and if it can speak to these larger disparities that we're seeing. So 2 examples. I took preterm birth out, too many examples. So I just have 2 examples and then I'm going to take us to solutions. So breastfeeding initiation, I know there's some experts in the room, but breastfeeding initiation is tremendous. I mentioned untreated depression is related to a host of factors. One of them is shortened duration of breastfeeding, okay? And this is a chicken and egg situation. I've had colleagues that publish both ways, right? So there was a case of depression, breastfeeding was too much, it didn't work out. Or breastfeeding wasn't working out, all the stressors, now we have onset of depression, okay? So it's a chicken and egg situation, but we know that there is this relationship. And breastfeeding itself is important because it's where the infant sets a course of immunity, gets all of the essential nutrients they need. There's newer research, I'm not a neurologist, on the neurological response of mom from breastfeeding and how it's a protective factor for mom as well in that postpartum period. So breastfeeding initiation is the best predictor that we know for breastfeeding duration. So you have to start to be able to breastfeed. The World Health Organization has this recommendation that 90% of all women are going to breastfeed for 1 year. Doesn't that sound beautiful? Our recommendations in the States are 6 months. And let's get to 82%. That's our goal, 82%, all right? And this goal has a lot of implications tied to it for practice and a lot of resources tied to it as well, okay? There are several funding opportunities where clinics can apply for funding to do breastfeeding awareness campaigns, do training, have lactation support and providers. And a lot of these are targeted towards specific disparities. So like NACHO is one major organization. Oh yes, Carlos Zameda. So Carlos Zameda, who is here at the University of Michigan, is now the deputy of this program, NACHO. And they have targeted initiatives for breastfeeding, okay? And one of their main targets is ensuring that African American women achieve this goal of 82% of breastfeeding, because nationally the rates are lower. So looking within our data, we used women how they identify themselves. Almost all of these multiracial women are black and, okay? They're black and another race. But we see, in terms of that 82% target, white women and Latino women, okay, followed by Asian and other race, are closest to reaching that goal. Where black women fall behind, and only 54% of black women initiate breastfeeding, and only 37% of multiracial women are initiating breastfeeding. So this paper came out last month in Health Equity, and our premise is that this matters. And our takeaway message is we need to start including these smaller groups and identifying those disparities that exist and maybe tailoring our approaches to lactation support that we're offering in clinics. And just showing you quickly the fully adjusted multivariate regression model, the significance remained where compared to white women, multiracial women are less likely and black women are less likely to initiate breastfeeding. And Latino women, the direction changed in the fully adjusted model to being less likely to initiate breastfeeding. Last example is on multiracial women and depression during pregnancy. So the breastfeeding sample with multiracial women is tiny. I get it, it's 1,000 people. But it's important because it's what's going on right now, real time in the clinic. The data was collected in 2015. In another data set in California, we use electronic medical records linked to birth certificate data. So these are linked records from delivery hospitals in Northern California, mostly the Bay Area. And this sample is oversampled for black, multiracial, and Latino women, okay? The funding comes from private donors who really want to find that silver bullet to addressing preterm birth and health disparities. So it's oversampled. And the study takes place here and throughout Eastern Africa. Okay? Of 1,358,750,000 pregnant women, so this is not weighted, this is the real number from the charts. 1.7, nearly 2% of women have a diagnosis in their charts. Okay, so it's very low. This goes along with our detection. And this is before California mandated depression screening, which was new just at the end of 2018. So nearly 2% of women have a diagnosis of depression. If we treat this how the CDC treats it, by looking at multiracial as a single category and the other races as single monoracial categories, okay? We find here that white women have the lowest diagnosis of depression, okay? This is why we need ongoing epidemiological data. This is my soapbox. Because the way that medical education is provided now, white middle-class women are going to have higher diagnoses of depression. You might find that black and Latino women have higher depressive symptoms. The problem with this data is that it's mostly coastal. They're middle-class women, usually seen at an academic medical center. So this is a wider sample than what we'd normally use. White women have the lowest rates of diagnoses during pregnancy. Black, Native American, Alaska Native, and multiracial women have the highest prevalence of diagnoses during pregnancy. And so that single category is interesting of multiracial and almost alarming. But we know that there are several mixes within multiracial. If you look at just national data, it's easy to break out 36 categories. And that's just the 2 or more. That's not the 3 or more people. So 8% of Americans have 3 or more races, and then those cells get smaller and smaller, okay? So if we look into specific multiracial groups, now we start to see that average broken up, okay? I am at the bottom here, this is white black, white American Indian, Alaska Native, white Asian, white Hawaiian Pacific Islander, because this is the Bay Area, black American Indian, Alaska Native, black Asian. And we see those prevalences differ, with white, black, and white Native having the highest diagnoses of depression during pregnancy. Quickly, we threw this into an unadjusted and an adjusted logistic regression model. And we compared these specific multiracial categories to white alone. So individuals who choose white alone. 4 of the 5 multiracial groups, okay, have increased odds of having a depressive diagnosis compared to white Americans. The only group that was not statistically significantly different were those who were Black, Asian, and white, Hawaiian Pacific Islander as well. So 2 of 6. We're excited by this work. We haven't seen work on the multiracial group since 2003 in terms of perinatal health, perinatal depression. So we think our findings are going to have some impact in terms of looking at the nuances within categories and the heterogeneity within categories. If you think of the case of breastfeeding, if we were to recategorize or drop the multiracial women in the sample, we wouldn't see that so few women are initiating breastfeeding, right? 30% of women compared to the 72, so they're farther from meeting that goal. A lot of the work that we do tries to translate these findings into meaningful terms for clinicians, because clinicians want to know how these large data sets, what this large data means for their everyday practice. We've been doing this work for the last 10 years, and it's changing swiftly. Let me tell you how it's changing, how it might affect you here in Michigan. So I mentioned untreated depression is bad. Hopefully that's the one thing you take away from here. We have to do something. Identifying women as early as possible is good. If we identify women during pregnancy, we can get them the supports they need before they go home, with a family who may or may not understand, and an infant who needs a lot of care. The public health approach to identify women in need of treatment referral and follow-up is to conduct screening. So that's using those paper tools that I mentioned, like the Edinburgh Postnatal Depression Scale, the Patient Health Questionnaire, the Hamilton Scale, and asking women a battery of questions about their mood, sleep, appetite, and desire to do things. My state, the state of Illinois, is the second state in the country to mandate perinatal depression screening. New Jersey was first, so we're second. Behind us are West Virginia, and most recently, California. Okay? These state mandates are important because it makes sure that mental health is discussed in primary care. It's really jarring and shakes the system up. I have on here a hotline for assistance, because something we hear from providers all the time is we screen them, but now what? So we conducted research with providers. This is a 2015 General Hospital Psychiatry paper. We wanted to know what they were actually doing with the screen and what the actual gaps were, how they felt that they could treat and refer. This was a qualitative study, so we spoke with providers. We had 4 groups where everyone's in a circle, and we recorded it. And their backgrounds were usually case management, nursing, nutrition, even lactation consultants. But these are all the people who were at the forefront of delivering that screen, scoring it, and walking through some sort of referral plan with their client. Because in this particular public health clinic, at the time, they did not provide any mental health care. They have a brand new grant that just came in for integrated healthcare. So they just started. Anyways, I'm just really happy for them. From these focus groups, we used thematic analysis, thematic network analysis, and we found 6 major themes. For this work, you have to take the themes and you put it back to the data to see if it makes sense. Only 5 made it. So there are 5 major themes that are presented in the paper. Just as we hear anecdotally, providers said they weren't prepared to address mental health in a clinic setting. They were trained in nutrition, dietetics, and here they are talking to someone who's crying. And they talked about the level of discomfort. And the particular clinics where we conducted the interviews, they said there were tremendous literacy barriers. We're like, oh, okay, because 1/3 are non-native English speakers. And they said, sure, it's them, but it's also the rural clients too. So they said subliteracy was a problem. They often found themselves reading the questionnaire, which should be self-administered. And they wanted assistance with this. Huge amount of stigma. And these particular clinics, they were just at the beginning, the front desk person was giving the client a depression screen and sending them back into the lobby. So they thought that there was stigma associated with it. And they also talked about serving low-income women and that there was surveillance. Like, we're asking these women a lot, and we're checking their homes, and we're talking about what they eat, we're looking in their cabinets, and now I'm talking to them about their depression. They don't need another layer of surveillance. Location of screening related to stigma, but there's more of that, of screening in the exam room, and also the privacy of the screen. When friends are translating or partners in the room, they wanted to know how valid screens are. And then referrals and follow-up. That's a fun discussion that could be another talk, because now we're doing something specific to this too. But they said, again, we're not mental health providers. We screen them. We don't know what happens. And they may or may not come back because of the transient nature of needing to enter a WIC program or needing a vaccination. These are acute things. So we may or may not see them again. Since the providers described the barriers to screening, the clinics wanted to do more with us. At the time, the funding structure prohibited them from doing anything related to mental health in public health clinics. And again, the doors just opened a year ago at our county level. They wanted to partner. This is them. They thought that they were broadening the horizon of public health districts by partnering in research. They wanted to get more involved, and they wanted to use the findings to improve their clinic practice. We formed a partnership between colleagues at the University of Illinois College of Public Health, who had expertise in groups, group formation, and qualitative expertise, the Public Health District, and then several of us at social work. And we formed the IDEA Coalition. This is new to us, because the IDEA Coalition called upon us to engage with patients as partners. So for several years, women had come forward and said, I want to engage in research, I want to do something was wrong, but we didn't have a place for them. We found one through this coalition. We asked for funding through PCORI, which is the Patient-Centered Research Outcomes Institute. This was money that was set aside from PPACA, the Patient Protection Affordable Care Act, also known as Obamacare, to have a layer of accountability to conduct research that starts where patients are, learns about informed decision making, and improves clinic practice. So at the core of PCORI, they want to see comparative and effectiveness research studies. Our funding was through a pipeline award. So it's a 5-year award to start by building a coalition, you come up with research questions, and then you launch a study and carry that out with patients at the helm along the way, okay? And especially in the dissemination process. So we applied and we won. So you and your clinic partners have money. What do? You yourself can't come up with the comparative effectiveness research questions. You yourself cannot design what those comparators are. That would be our standard health services research. But this comparative effectiveness research is what people are also calling implementation science, right? We have patients at the helm. They're going to help design a comparative effectiveness research study comparing two things. It makes sense to them, it makes sense to the clinic, and clinics can implement. So we sought out to get patients. We didn't know where those patients went across the years that were interested. We threw expos. We're having our next expo March 30th if you're in Chambana. Stop by. But we threw a pregnancy expo and solicited for applications to the board. We hosted a town hall where we advertise these things on the radio and bus ads and newspapers and give out flyers. And people came out. This day it was negative 30 degrees, and they came out to talk about what's broken in our community. So you see this is a huge area of interest. We held coffee hours, again, to solicit invitations. If you give a new mom or even new dads a chance to come and talk about their experience in a space where they can drink coffee with the lid off because you're watching their kids, they come. So we provide childcare and we assist with transportation just to make sure that folks are in the room. And 42 applications later, we had an advisory board. So we received 42 applications for a 10-person board. We have this amazing advisory board. So this is the first day that we met almost a year ago. So it's a little less than a year. And they're bright-eyed, but they're also very disgruntled. So after this picture, they said, what are we doing here exactly? And we went through PCOTS, okay? A framework for developing CER questions. So PCOTS for the public health people are like, yeah. For everybody else, it's identifying a population, an intervention, the comparator, the outcomes, the timing, usually the timing of treatments, and the setting. And then with all this, does it align with PCORI? The board did it, okay? The board established PCOTS framework. Everyone on the board's completed city training. So a year ago, I teased them, like a year ago, like, wait again, what do you want from us? I applied for the board to do more awareness activities, to let people know about depression, to share my story. What is this research stuff? Less than a year later, they've developed their own interview guide. We've applied for 4 grants, right? We've won 2 of those new grants. We weren't invited for LOI, a letter of intent, and that was crushing to everyone, even though we were like, 2 for 3 at the point. And now we've applied again. As our collaboration grew, it took notice, so the local news outlets, NPR, everyone started taking notice of our group. Like, what is this? Patients deciding what clinics should look like, patients doing research. We were contacted by a company, Neurostar, to give us a machine if we wanted to do a study on transcranial magnetic stimulation. Okay. And we ran it past the board. Is this where we want to go? Is this the treatment that we want to look at? We formed a partnership with the University of Iowa, who said, we're not doing enough as researchers. We want to start a board too. So they now have a patient advisory board, patients at the helm, designing their research. And we partnered with colleagues at UCSF to look at some of those disparities. That's the California data that I showed you. This is all in the last year. And All Our Kids networks are home visitors that ask to come to our events and learn more about our group. This is my last slide in terms of content, but I'm just so proud of the advisory board. I'm so proud. So the advisory board consists of mostly patients. These are women and men who've experienced perinatal depression and/or anxiety. And they show up. Everyone, when we started, said, you're never going to have a board. People with depression just lay in bed. We've had quite the opposite. People are fired up, just like the celebrities, just like Christy Teigen. They say, why didn't anyone talk to me? Why didn't I receive a follow-up? I think I answered really high on that paper thing. So the research question that our board has come up with is, does any screening for depression during pregnancy reduce rates of postpartum depression? So we're using data from 2 major hospital systems in Iowa and Illinois to just look at screening for depression during pregnancy, because right now we don't have the evidence if screening is effective, okay? And the second question, they're very fired up about this. This is qualitative, and this is a mixed methods design that they've come up with. It's an explanatory framework to fill in the holes in the quantitative data. They want to go out and do interviews with 240 women across 2 states and 4 comparator groups to see how does screening inform patients' experiences and the decisions related to their treatment, right? So looking at decision-making behavior. It's really exciting because in less than a year they've come this far. This proposal is under review right now, and it would provide 3-year support for a fairly substantial project where patients are at the helm throughout. Follow us on Twitter, please. Shameless plug for our coalition. It works. We solicited our last round of applications through Twitter, and almost all of them were local. And before I end, I'd like to acknowledge the members of the advisory board, my team. None of this happens without the team of residents and students from PhD to undergraduate who are really making all of this happen. My mentors who taught me the pieces I know, my family, and then all of our sponsors. So with that, I say thank you for your attention. Yeah. So, are we entertaining questions?
Yes.
Or yes? Yes, hi, Gloria.
So at our clinic, we screen, and it's the patient is supposed to do it themselves, and we're finding they're not answering, or they have to have somebody reading for them, and then the person's reading for them is not as comfortable. So there's a lot of issues around getting a complete
Screen
response
Yeah.
to the questions. How did you deal with that?
There's no good answer right now. We published a paper on mHealth technology. So using a mobile version of the screen, and Mass General just came out with a mobile tool in the last 2 years to help providers with just that. But our clinicians want it in several different languages, and they want it audio assisted. When we published the paper that was just ideas, the phone started ringing from clinics, from Tacoma, Washington to London, England, that said, so we want this. When do we start? I said, no, these are just findings from the idea of providers of what they need. So, I mean, that sounds like the solution. It's just we need someone to develop it. So, the way that the data is scored, though, to answer the second part of your question, is if it's missing, they just treat it as 0 in the clinic. So, that's the provider education piece and the comfort level piece. So, yes?
Just related, did you come up, I know at TAS when we originally started, it was not self-administered, it was administered by a staff person. And did you come across any literature that, I mean, across the country, they must be dealing with this, otherwise you'd have systematic
under-reporting, yeah.
literacy and second language and other issues. Did you find any examples?
No. Of working with the patient and reading it to them, no.
Yeah.
And there's so much variability in our clinics. If you think of the public health clinic, some case managers read it, some don't. If you think of our healthcare systems where we do a lot of our training, the standard of care is to leave it on the counter in the exam room with a pen, and the MA picks it up, transcribes it, and then depending on the provider's comfort level, they may or may not address it. That's the qualitative piece that the patients want, to learn all this variability. And that's only in OB clinics. It's not even getting into peds and other units. Yeah. Yes?
So your board, you talked about a big geographic area across 2 states and everything. So is this board made up of people from all over like that? And if so, how do you address meetings?
Yeah, so now we have 2 boards now. And being in Illinois and Iowa, they're the ICABs. So everything has to have I. But our 2 different advisory boards are very different. I know much less about the Iowa board. So they had their first meeting in October. And I'm starting to learn who they are. We'll meet for the first time. We have a new PCORI funded project that has funding for us to come together now. And we'll meet for one of our trainings in May for the first time. Our board in Illinois represents several surrounding counties. That's not what we were funded for. We were funded to address county level factors, in Champaign County being the hub for the center of the state. But from the moment we had our first expo and coffee hour, it became a regional issue. So now a lot of the stuff we do it's 2 counties over, the next large county is the home of Illinois State University. And then 2 counties over from them, Peoria County, so 90 miles away and 50 miles away, they drive in. And from the south, from Charleston, which is the home of Eastern Illinois University, they drive in. These people drive in just to have coffee. And our board is representative of that. So we have board members who are living in these rural counties that drive in for our meetings. All the meetings are on Saturdays, and we provide childcare. So we stopped providing transportation. We didn't need it, but they come in, yeah.
Just curious, you talked about the town hall meetings, coffee talks. I saw a happy hour on there.
Yeah. Oh, the reviewers didn't like it. So we did do happy hours, yes. The happy hours are a different population. So where we live in central Illinois, with lots of corn, there are really great breweries. And a lot of the breweries have playgrounds. So a lot of the parent groups in town meet at the breweries. Kids go on the playground and they have a sampler. So it's the culture of where we live. That was very clear when we got our funding. You guys can do these happy hours. We're not paying for it. So, well, no, we were able to buy food. So we had happy hours, but we noticed there were almost all providers. The first couple were great.
Now I know how to get providers somewhere.
Yeah, and you do it near the hospital. The brewery near the hospital, too. They come. But it was almost all providers. And there were just weird dynamics. And when we first started, the patient's like, that's the one that messed me up. And we're being recorded. We're being recorded. But weird power dynamics with these happy hours with who is in the room. And they work. They work. They're just expensive to maintain. People are hungry. We only buy food, but they eat a lot of food. So, yeah. Any other questions? Yes?
I just feel like commenting that the positive energy in your recycling product just feels nice to listen to.
About depression or about the... Okay. Yeah. The board is invigorating. So it's, yeah. Yeah, we're going to come up with different solutions from everyone who's experiencing the condition. Even, so the first time I won funding from PCORI, I applied as a patient. I applied as a patient researcher because I've had several pregnancies and now I get screened. Before I was always the person implementing the screener, and now that I experience, I'm like, whoa, that's what they do? This is my data? So it's been very different. So I applied as a patient the first time, and PCORI came back and they're like, no dual roles. So even though I'm a patient researcher, the questions I ask are night and day different. Like if you see the interview guide that my group came up with, it's amazing. And never in a million years would I come up with the level of inquiry that they have. None of us, none of the researchers on the board. So there's psychologists, people from education, people from public health. We're all so impressed. It's just so different. So I think that's what's neat. After singing the same song, last time I'm like, oh yeah, this data is new. These are new findings with the clinical epi data. It's also like, yeah, it's just another problem. What do we do about it? So the patients, I think we all feel the magic. It's hope that we can change. Yeah. Yes?
I have a couple questions about your board members.
Mm-hmm.
So are they, you said they're all parents, right? Or primarily?
Primarily,
Okay.
yes.
And they're not paid, right? So they're all volunteering to be there?
They're paid, but with research grants, there was just a gap. Yeah. So they are paid as long as we have funding from the grants. It's an honorarium for their time to be there. And then they're paid as interviewers. So we receive study to do the pilot and feasibility of the interviews before we do the big study. And they're all paid as interviewers.
That's good. I was going to say, it sounds like a lot of work. So I wondered, are they like mostly stay-at-home parents, or are they people that have full-time jobs and then do this on their Saturdays?
Yeah, I mean, that's the thing. So in the last year, I don't know how we're going to address this and or write about it. I said 10-person board. Well, we got a little trigger happy. We had a 15-person board, okay? And when folks are in it, they're excited, right? But over the course of a year, with people with young children, life is happening. Employment opportunities change. And so people go from not working with a 6-month-old, and they're like, wow, I just made it through this episode, and it was so bad. I have to do something. So they work full-time, and they give me the soft resign. So I'm just so busy, I'll make it to the next one. So that's why we just solicited more application to get more hands. But it's a mix. We do have some stakeholder partners too. We have providers and administrators on the board that are full-time people. Everyone is a parent, maybe not the birth parent. So we have same-sex couples and fathers on the board, and one person was an expectant family. So they were there like, I don't know what to expect. I want to be ready for this mental health thing. Yeah. Yes?
You mentioned that they came up with different questions. I wonder if you could share some of them.
Without having the interview guide, we just, in our grant proposal that went in last week, we framed around the health belief model. So while we were really interested in like more of the language factors and the communication around the screening, timing of the screening, resources and follow-up, I mean, we as the health services researchers, the patients on the board were really more concerned with quality of the screen, compassion of providers. The training thing is important, but they were more concerned with the perceived training of the provider to handle the situation. Clinic was most important to them too, so that's the whole thing about pediatricians' offices. My head is always in OB. Maternity units, OB, and I'm not thinking about the broader spread. In the state of Illinois, home births are illegal, but that's come up too. Again, not in my sphere. I'm thinking the hospital delivery system. So how do you go for follow-up care and treatment if you didn't deliver in the system? Those are some of the questions. So right now we're in the process of cleaning up the interview guide. The questions that they came up with, it was so cool. We do all these activities together to do like brainstorming and mind mapping. We vote a lot with stickers on sticky paper and prioritize topics. So the research question interview, it was, or the creation, the research questions for the interviews, I'm not speaking English, was like a round robin. And then they went back and wrote things down quietly. And a lot of the questions that they wrote down are really survey questions. So they're not really appropriate for open-ended responses. So we're in the process now of splitting out that guide. So we'll have some survey items and then some more open-ended questions. Again, the new things are like quality of screening and perceptions of place, or like confidence in your provider's ability to handle the situation. So, yeah. Okay.
Okay, we'll let that be the last question.
Thank you.
Please thank Dr.
Tabb, Dina.
Tabb.
Thanks.
So let me just mention, I'm so used to carrying Tabb as an MSW student.
Yes.
So it's hard for me to get remember the Dina part.
Yes.
So again, let's please thank Dr. Karen Tabb, Dina.
Thank you. Thanks, everyone.